Hello everyone, I'm Alan, your friendly neighborhood geriatrician from Penang. Thanks to the MCGM committee for having me here today, and many thanks to Pfizer for sponsoring this talk. I'll try to make a case on why older people need to take pneumococcal vaccine, and hopefully by the end of this sharing, convince you to consider pneumococcal vaccination in older adults seriously. Malaysians are living longer. Life expectancy at birth was 55 years in 1950, and today it's around 76 years. Increases in life expectancy are greeted with enthusiasm because these figures really tell us something about the health of the whole nation. We can't expect more people to live beyond 90 if we haven't made some progress in improving health at 60, 70, and 80. At the same time, the crude birth rate is downtrending. Due to reduction in both death rate and birth rate, you get an increasingly older population, and Malaysian population pyramid structure is slowly transforming into an aging population. These are the population pyramid and projections for Malaysia. As Malaysia undergo demographic transition, the pyramid slowly turns inverted as middle-aged people become the majority. Increasing life expectancy and extreme old age come together with fear of the possibility of pain, loneliness, and most of all, loss of independence. From the economic standpoint, less people are paying taxes while government expenditure to support pension, healthcare, and social care increase. In the UK, when her population was 15% elderly, that 15% consumed almost half of the funds for the NHS and social services. Imagine when it gets to 30% like in Japan. Improving life expectancy is no doubt important, but more important perhaps is the healthy life expectancy, or how long we can expect to live independently and free from disability. Therefore, it is for the best interest of everybody, the older person, the family, and the government, to promote healthy life, keeping functional independence as long as possible, what we term as compression of morbidity. After a minor illness, a fit older person remains independent, but in a frail older person, even a minor illness may lead to deconditioning, causing him to become bedridden with loss of independence. If we can reduce the risk of illness and hospitalization, it is well worth the effort and investment. In this study, they examined the impact of inactivity on the loss of lean leg mass. For healthy young people, there was loss of half a kilo after 28 days of inactivity, whereas in an older patient, after hospitalization for just 3 days, they lose 1 kilo or 10% of the total lean leg mass. Maintaining independence, disability-free aging with good quality of life are important goals. The return on investment for prevention is definitely much better than treating complications, followed by long periods of rehabilitation, as some may never regain their pre-morbid function. Pneumococcal disease. Strep pneumoniae are gram-positive diplococci. The capsule of the pneumococci is made of polysaccharide. Right now, over 100 different capsule types have been identified, and this forms the basis of antigenic serotyping of the organism. Highly immunogenic antibodies to capsule provide protection. The pneumococci has several mechanisms to evade the immune system. It has a capsule that interferes with phagocytosis by preventing C3b opsonization of the bacterial cells. It has a protective antigen of PSPA, which inhibits complement-mediated opsonization. It has IgA protease, which chops up the IgA immunoglobulins, and neuraminidase, which cleaves the host cell surface receptor for binding to pili of pathogen. It has pneumolysin and hydrogen peroxide, which cause lysis of host cells, apoptosis in neuronal cells during meningitis, and also septic shock.
Now, one of the biggest problems the world has is the germ has gotten so brilliant. The germ has gotten so brilliant. People go to a hospital and they go for a heart operation, that's no problem, but they end up dying from problems. You know the problems I'm talking about.
The problem is age. Age is one of the most significant risk factors, as pneumococcal disease disproportionately strikes individuals with an aging or immature immune system. Immunosenescence refers to the deterioration of the immune system brought on by natural aging process. In short, it is an age-associated immune deficiency. There is progressive deterioration in the ability to respond to infections. For example, there is changes in the innate immunity, reduced phagocytic capacity. As the thymus atrophies, there is reduced naive CD4 T cells, which are important for B cell maturation to plasma cells and memory B cells. Community-acquired pneumonia exerts a substantial burden on older adults all across the world. In this regional epidemiological study on invasive pneumococcal disease in Asian adults, in Malaysia, hospitalization rate in adults more than 65 years was 20.4 per 1,000 population. In Singapore, the overall mean annual hospitalization rate due to pneumococcal disease was 10.9 per 100,000. But in older adults more than 65 years and above, it is 56.3, or five-fold that of the overall. And in Taiwan, it is again five-fold, and in Thailand, around four-fold higher in older adults. Epidemiological surveillance in both the US and the UK, the youngest and the oldest age groups have the highest incidence of invasive pneumococcal disease. Between 2008 and 2010, a prospective observational cohort study in 2 large UK teaching hospitals found that over 2 years study period, 366 out of 920 patients were determined to have pneumococcal community-acquired pneumonia. The estimated annual incidence of pneumococcal community-acquired pneumonia increased with age from a low of 12.1 per 100,000 in adults aged 16 to 44 to a high of 274 in adults more than 85 years of age. In this retrospective cohort analysis, chronic conditions put patients aged 18 years and older at increased risk of pneumococcal pneumonia. For patients aged 65 years and older, are already at increased risk for pneumococcal pneumonia, which increases even further with the presence of chronic conditions. Having multiple risk factors for pneumococcal pneumonia increase risk. Those patients with at least 2 at-risk conditions have a risk of pneumococcal pneumonia equivalent to that of a high-risk patient. A total of 151 pneumococcal isolates were obtained from the clinical samples processed at the microbiology lab of University of Malaya from 1999 to 2007. And they found that 21.2% were penicillin resistant, 29.1% were penicillin intermediate. Serotype 19F and 23F were predominant among local populations. Respiratory tract remains as the most important clinical site for pneumococcal infections, where large numbers of isolates were recovered from the nasopharynx, sputum, and tracheal secretions. The majority of clinical isolates were obtained from non-invasive sites, 72.2%. Among the non-invasive sites, sputum and nasopharynx constituted the two main sites where pneumococcal isolates have been frequently isolated. Serotype 19F was the dominant serotype in these two clinical sites. In addition, sputum, nasopharynx, and blood represent the three major sites of pneumococcal isolation, which accounted for 77.5% of all isolates. In this 8-year prospective study on nursing home acquired pneumonia involving 15 local clinical centers throughout Germany, 3,087 hospitalized patients aged more than 65 years were included. Streptococcal pneumonia was the predominant culprit. The short-term mortality was nearly fourfold higher in the nursing home acquired pneumonia group compared to the community acquired pneumonia group, 26.6% versus 7.2%, and the long-term mortality nearly threefold higher, 43 versus 14%. The excess mortality results from higher comorbidities and pneumonia frequently being considered and managed as a terminal event of advanced age and poor functional status. This paper looked at the risk factors for death in invasive pneumococcal disease by analyzing data from National Surveillance Case Notification System of 26 European countries. Compared to age less than 5 years old, people more than 65 had a 4.79 relative risk of death. Meningitis had a 1.8 relative risk of death versus non-meningitis. And within the PCV13 vaccine, if we just look at the PCV7 versus other serotype within the PCV13 which are non-PCV7, there was a 2.18 relative risk of death. The other serotypes not in the PCV were not statistically significant. Penicillin non-susceptibility strep pneumonia had a 1.91 relative risk of death compared to those susceptible. Next, let us move on to the effectiveness of pneumococcal vaccines in adults. PCV13 has 12 serotypes that are also included in the PPSV23 and one unique 6A serotype. PPSV23 has additional coverage of 11 serotypes, not inside the PCV13. In a double-blind randomized controlled trial involving Japanese nursing home residents and using urinary antigen tests, PPSV23 arm had a 63.8% reduction in pneumococcal pneumonia compared to placebo. In this capital trial, the community-acquired pneumonia immunization trial in adults, this is a large, double-blind, randomized, placebo-controlled vaccine efficacy trial that included a total of 84,496 adults aged 65 years and older in the Netherlands. The CAPITA trial evaluated the efficacy of PCV13 in preventing the first episode of vaccine-type pneumococcal pneumonia, non-bacteremic and non-invasive pneumococcal pneumonia, and invasive pneumococcal disease in those aged 65 and older. The primary endpoint of CAPITA study was to demonstrate the efficacy of PCV13 against the first episode of vaccine-type pneumococcal pneumonia that includes invasive and non-invasive cases. And these are the inclusion and exclusion criteria. In the per-protocol population, PCV13 had significant efficacy against the first episode of confirmed vaccine-type pneumonia. The efficacy was 45.6%. Against confirmed non-bacteremic and non-invasive pneumonia, the efficacy was 45%. And the vaccine-type invasive pneumococcal disease, the efficacy was 75%. What about the duration of protection with PCV13? Let us look at the rationale for conjugation. On the left is the polysaccharide vaccine. On the right, the conjugate vaccine. Polysaccharide vaccine contains polysaccharide antigen, which stimulate B cells to produce antibodies. Therefore, it is a T-independent immune response. On the other hand, conjugate vaccines contain polysaccharide antigens covalently linked to a protein carrier, and this stimulates T cells to help B cells produce antibodies and generate immune memory. In other words, conjugate vaccines stimulate T cell dependent immune response. In a post hoc analysis of the cumulative episodes of the primary and secondary efficacy endpoints, shows that the persistence of PCV13 efficacy against all episodes of vaccine-type pneumonia throughout the duration of the study. In a phase 4 open-label randomized parallel trial conducted in the UK involving adults aged 50 to 70 years of age, they wanted to look at the efficacy of 3 different vaccine schedules on the B cell immune response. 28 days post-vaccination, participants who received a single dose of PCV7 showed an increase in memory B cells frequency from baseline, whereas those who received a single dose of PPSV23 showed a decrease. In a phase 3 randomized modified double-blind active controlled multi-center trial conducted in the US involving subjects naive to the 23-valent pneumococcal polysaccharide vaccine. So those aged 60 to 64 years were randomized to receive either PCV13 or PPSV23 first. Subjects aged 50 to 59 years received PCV13 only as a first dose, and all groups received a second vaccination with either PCV13 or PCV23 3 to 4 years after the first dose. And what they did was, they measured the opsonophagocytic activity at the time of the first dose, 1 month, 12 months after the first dose, and at the time of the second dose and 1 month after the second dose. At 1 month following the first dose, the response to a single dose of PCV13 was at least as good as the response to a PPSV23 for all of the serotypes, and statistically significantly higher for 9 of the 13 serotypes. The response to a dose of PCV13 in those aged 50 to 59 years was superior to those response to people in older age group 60 to 64 years. In the follow-up study conducted about 4 years later, Adults aged 60 to 64 years initially given PCV13 received PCV13 or PPSV23, and those initially given PPSV23 received another PPSV23. All adults aged 50 to 59 years were revaccinated with PCV13. Initial vaccination with PCV13 established an immune state that resulted in recall of anti-pneumococcal responses upon subsequent revaccination with either a conjugate or free polysaccharide vaccine. To recap, PCV13 induces a T-cell dependent immune response that can be recalled or boosted by a subsequent dose of PCV13 or free polysaccharide vaccine. By priming the immune system, PCV13 provides the potential to significantly enhance and prolong immune protection by response to either natural exposure or to booster vaccination. There has been a sharp decline in the invasive pneumococcal disease when PCV13 was introduced to be used in children. According to the ACIP 2019 guideline, shared decision-making for PCV13 use is recommended for people aged 65 years who do not have an immunocompromising condition, CSF leak, or cochlear implant, and who have not previously received PCV13. When patients and vaccine providers engage in shared clinical decision-making, consideration may include the individual's patient risk for exposure to PCV13 serotypes and the risk for pneumococcal disease for that person as a result of underlying medical conditions. The ACIP recommendation for adult pneumococcal vaccination for older people is based on whether the person is immunocompetent or immunocompromised. For immunocompetent older adults, the decision to take PCV13 or PPSV23 is based on shared clinical decision making. So the person may choose to either inject one dose of PPSV23 or you may opt to inject PCV13 followed by PPSV23 after 1 year. For immunocompetent person with cochlear implant or CSF leak, the recommendation is to give a PCV13 vaccination followed by PPSV23 after 8 weeks. For older adults who are immunocompromised, it is recommended to give PCV13 followed by PPSV23 after 8 weeks. So this diagram summarizes the recommendation. There must be a gap of at least 1 year between the PCV13 and PPSV23. And the gap between 2 doses of PPSV23 must be at least 5 years. What about the Malaysian guideline? The MSIDC 3rd edition, year 2020, recommends a PCV13 followed by PPSV23. This is the preferred sequence. If 1 dose of PPSV23 has been given, then you need at least 1 year before the PCV13, or at least another 5 years before the next PPSV23. So basically, the MSIDC 3rd edition 2020 guideline is in line with the ACIP guideline. There must be a gap of at least 1 year between a PCV13 and PPSV23. And there must be a gap of at least 5 years between 2 PPSV23 vaccines. Adult vaccination with PCV13 is now recommended in over 50 countries worldwide as of January 2020. So the key takeaways: aging leads to an immunodeficient state. illnesses and hospitalization gravely impact older people. The incidence and mortality rate of pneumococcal disease is multifold in older adults compared to younger people. Ideally, PCV13 should be given first, followed by PPSV23 after at least 1 year for immunocompetent older adults. Ladies and gentlemen, the message is clear. Prevent it before it's too late. Thank you.